And welcome everyone to the second lecture of our Winter 2008 Geriatric Healthcare Lecture Series. My name is Barbara Cochran and I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this lecture series with the School of Nursing. And I just want to remind the attendees and the sites, if you haven't filled out a participant profile form yet, please do so. We do need one profile form for each series, and that's one of the ways that we document to our funding agency to keep sending us money. And then you should also have evaluations and a handout of the slides for this series. And if you don't have that information, your site coordinator should be able to get it for you. Today, I'm very, very happy to introduce Jennifer Kapur. Am I pronouncing that right? Jennifer is trained as a primary care pharmacist. She spent the majority of her career working at Harborview Medical Center here in Seattle, where she currently practices. She is a mentor and facilitator for the Interprofessional Education Program at the University of Washington School of Pharmacy, and is in her 18th year teaching pharmacology to nursing students at Seattle Pacific University. She's been providing continuing education about medical marijuana for nurses, pharmacists, and physicians, speaking at local and regional conferences for the past 3 years. This is a topic of great interest to us in gerontology, so we're so pleased that we have someone with this expertise. Jennifer is going to talk with us about an evidence-based review of marijuana, a clinician's guide. Oh, let me just say one more thing. And please, if you wouldn't mind, save your questions for the end, put them in the chat box, and I will go ahead and read them off at the end of the lecture.
All right, thank you. It's a pleasure to be here today to present this evidence-based review of marijuana for healthcare professionals who provide care to older adults. I like to begin by letting you know that I don't have extensive experience working with patients who use marijuana. So I'm trained as a primary care pharmacist. So obviously I've talked about marijuana, both recreational and medical, with my patients, but I'm not a medical marijuana pharmacist per se, because I don't think there is such a thing. And I like to let you know up front, because sometimes I think there's an expectation that I'll be able to share very explicit directions and instruction on how to obtain and use marijuana, and I unfortunately am not able to do that. But what we will be looking at today is, what is the evidence, what is science telling us about the use of marijuana in older adults thus far. The other thing I'd like to do is maybe just kind of state the obvious, that marijuana is a controversial topic, and it can be polarizing among healthcare professionals, and I've seen the gamut. So people who are, vehemently opposed to the use of medical marijuana, to those who are big proponents. And I think probably most of us fall somewhere in the middle, but I'd just like to take a moment for us to recognize and acknowledge that our views about marijuana are not homogeneous. So with that, so the overall goal today is that you learn more about or reinforce your knowledge of marijuana so that you feel more comfortable and confident talking about it with patients. Because regardless of what your views may be, the use and acceptance of marijuana has increased in the US, and that means that its acceptance and use is increasing in our patients. So to meet that overall goal, the objectives are to compare and contrast federal and state laws regarding the use of marijuana, to differentiate the components of marijuana, to compare and contrast dosage forms of marijuana, and finally to really look at the risks and benefits of medical marijuana use in particular. So before we get into some of the legislation regarding marijuana in the US, I think it's helpful to look at a history of marijuana, particularly the history of medical marijuana, so we can see how it fits in with recreational marijuana. So marijuana has been used as both a medicine and as a recreational or spiritual substance for thousands of years. And it's thought that over 4,000 years ago, the medicinal properties of marijuana were discovered or first recognized in China. And since that time, throughout the ages, patients have used marijuana to treat things like pain and spasticity, seizures, which are reasons today that a lot of patients seek to use marijuana. The introduction of marijuana to Western medicine occurred in the mid-1800s, and it is often credited to the Irish physician William Brooke O'Shaughnessy, who was practicing medicine in India, and he saw the use of marijuana or cannabis there to treat things like pain and spasticity. He wrote about that in medical journals, and that is how marijuana was introduced to Western medicine. I've included an ad on this slide for Cannabis Americana, which was manufactured at the time by Park Davis and Company, a well-respected drug company at the time. And that's just to illustrate the legitimacy with which marijuana was used as a medicine in the 1800s. So it was in 1851 that marijuana was formally added to the U.S. Pharmacopoeia. And you can think of that as being the formulary for the nation, so it's all the drugs available in the U.S. And as I said, during the 1800s, it was used by physicians to treat different ailments. After the turn of the century, there were a couple of changes that occurred. Number one was that we were kind of moving away from using plants and herbs and tinctures as medicines to using chemicals synthesized in labs and formulated into nice little white tablets. But probably more importantly for marijuana was that there were certain groups, some with a religious affiliation, who were very opposed to the use of marijuana. They were particularly concerned about the recreational use of marijuana and the deleterious effects they felt were associated with that use. And so they really went after marijuana. And so in some states or places, they had, laws reducing the use of marijuana or banning the use. And then there was one individual in the federal government who was also really going after marijuana. And what ended up happening was that in 1942, against the advice of the American Medical Association at the time, marijuana was removed from the U.S. Pharmacopoeia. So physician groups were saying, we know we're using this for our patients, and maybe it does have, some bad effects, but, we should really study it before we just completely remove it. But with that removal, that removed any legitimacy of using marijuana in the U.S. as a medicine. And then to kind of make matters more complicated, when the Controlled Substances Act was created in 1970, it classified marijuana as a Schedule I controlled substance. And so just to review, in case you're unfamiliar or need a refresher about the Controlled Substances Act, that allowed the government to categorize medicines based on their abuse potential, or substances based on their abuse potential. And there are 5 schedules, Schedules 1, 2, 3, 4, and 5. Schedule 1 has the highest abuse potential, and as you go down, the 2, 3, 4, 5, there's a decreasing abuse potential. Schedules 2 through 5 have accepted medical use, and so those are prescription drugs. An example of a Schedule 2 is, morphine or hydrocodone, oxycodone, going down to a Schedule 5 substance, which is something like codeine cough syrup. But marijuana was classified as a Schedule 1, so thought to have the highest abuse potential and no accepted medical use, and this making it basically illegal or illicit in the U.S. And I think that's led us to this kind of conundrum as healthcare professionals today, where over half the states, by popular vote of the people, have approved the use of medical marijuana, and yet as a medical community, we are really lacking in some of the evidence to support the use of marijuana for the variety of conditions that patients seek to use it, because it's very hard to study a drug that's illegal or illicit. Who's going to fund the study, who's going to provide the study drug, et cetera. So because of this, individual states sought to get medical marijuana approved or available for their residents. California was the first state to legalize medical marijuana in 1996, followed 2 years later by Alaska, Oregon, and Washington. And currently there are 29 states and the District of Columbia, in addition to the U.S. territories of Guam and Puerto Rico, that have all legalized medical marijuana. This figure shows a timeline of state marijuana policies. The circles in yellow indicate states where medical marijuana legislation has been passed and what year that was done. The circles in white indicate states where recreational marijuana law was passed and what year. And you can see that certainly in the last 5 years, there's been kind of a flurry of legislation passed in various states. And right now we actually have 8 states plus the District of Columbia that have all legalized recreational marijuana. This is just a kind of a different way to look at the information, also with a little more detail. So this map of the US, the states in the darkest color green, which may actually almost look black on your screen, are the states where there are both recreational and medical marijuana laws passed. And again, that's 8 states plus the District of Columbia. The states in the kind of medium shade or Kelly green are states where there's comprehensive medical marijuana legislation passed. And then the states in the lightest shade of green are those that have allowed a very specific form of marijuana, a product that contains mostly just CBD or cannabidiol, and we'll talk about what that is in a minute. And that's usually, patients seek to use that to treat seizure disorders. And then finally, you see the states in gray. So there's only 7 left.
Would you mind saying a few words, just to make sure?
Oh, okay. United States marijuana laws.
Okay.
That we're on?
Yeah.
Okay.
We should have that now. Thank you so much.
Yeah. No problem. All right. So one thing about obviously when states have different laws, they're not going to be the same. So there's a lot of heterogeneity between states, regarding who can authorize marijuana, and in particular what kind of conditions marijuana can be used to treat in those states. And so the next 5 slides are, specific to Washington State, and I realize that most of the participants today probably don't reside in Washington. So I'm really using these slides to talk about similarities amongst states that have medical marijuana legislation and some things that I think are important for all of us to understand, regardless of if we live in a state that has a marijuana access law or not. So this is just a list of providers in Washington State who can recommend medical marijuana. Obviously, this will change state to state, but the key word here is recommend. So because it is illegal to prescribe a Schedule I substance, the federal government says that's illegal. Semantics are important here. We don't want to talk about giving the patient a prescription or prescribing marijuana. Providers are giving a recommendation or authorization to use medical marijuana. And that, in some states, patients may get a medical marijuana card, with that recommendation or authorization. But again, it's not a prescription. These are just some, nuts and bolts of what a provider has to do in Washington State before providing the authorization. But I want to look in particular at number 3, which is to document a qualifying condition in the medical record. So these are the qualifying conditions in Washington State. This is going to vary widely state to state. For instance, in Alaska, they have about half of the qualifying conditions listed here. Some states will have, over 20 qualifying conditions. And I think the important thing to note here is, to understand, and especially so that we can help explain to patients, is that these lists are not evidence-based lists. Just because a condition is on this list does not necessarily mean we have evidence to support the use of marijuana for that condition. And the other thing is these lists are not necessarily come up with input from healthcare professionals. So, these are things that are, in some states they will, get the advice and recommendation of healthcare professionals maybe more than other states. But the bottom line is it's not evidence-based. And just to give you an example, like post-traumatic stress disorder and traumatic brain injury were just recently added in Washington State a couple of years ago. At that same year, Colorado also looked to, or evaluated adding them to their list of qualifying conditions, and they declined to do so based on the fact that there was not evidence to support the use at this time. So, all right, that's okay. Again, just some more nuts and bolts, but I'll point out, and this is probably true in a lot of states, that the authorization may have to be printed on the tamper-resistant paper, which we write prescriptions on. But again, it's not a prescription; it's an authorization or a recommendation. And then, if you live in Washington State, I did just want to point out that we updated our medical marijuana legislation 2 years ago in 2015. So, if you're not familiar with the Cannabis Patient Protection Act, this is just a summary of some of the changes that occurred in Washington State. And then, wherever you live, this kind of information, if you do have a marijuana access law, or medical marijuana law in particular, could be found on your state's Department of Health website. Okay, so now that kind of concludes looking at, or gives a brief overview of some of the laws regarding marijuana in the U.S. So, specifically looking at older adults. So do older adults use marijuana? Yes, they do, and the prevalence is increasing. And do they use medical marijuana in particular? They do as well, but the prevalence of that is unknown. So let's first take a look at just the use of marijuana in general in older adults. So this graph shows past marijuana use in the U.S. by age group from the years 2003 to 2014. So you can see the orange line shows young adults aged 18 to 25, and past year use did increase over that time period. In adolescence, the blue is represented by the blue line, and you can see that actually decreased slightly and then kind of stabled off. And then, and then finally, in the gray line, you see individuals aged 50 and over, and you can see there was definitely an increase in past year use in that age group. This is from another survey by the National Survey on Drug Use and Health, and this looks at the prevalence of past year marijuana use and disapproval in the U.S. From the years 2002 to 2014. And this first slide shows adults aged 50 to 64 years of age. And what you see in the red line is the prevalence of past year use, and it is increasing. And then the darkest gray area on the bottom shows individuals who strongly disapprove, and you see that's decreasing. It may be kind of hard to see, but then there's another area where with light gray shading, and that shows where individuals somewhat disapprove of marijuana use. But in summary, you can see that the disapproval of marijuana use is decreasing while the prevalence of past year use is increasing. And this is just that same survey, but looking at individuals age 65 and over, and you can see the same scenario with past year use increasing and disapproval decreasing. Okay, so next we want to kind of talk more about the pharmacology of marijuana, but first we need to go over some definitions. So there's this term cannabinoids, and I divide it into 3 categories. So endocannabinoids, phytocannabinoids, and cannabis-derived pharmaceuticals. So endocannabinoids are just the endogenous cannabinoids our body makes. You may have heard of anandamide. There's also 2-AG, and these endocannabinoids interact with cannabinoid receptors in our body as well as other targets to produce a variety of effects. The next term, phytocannabinoids, are the cannabinoids which come from plants, and this are from the cannabis plant. And this is what marijuana or medical marijuana, that's what this is the cannabis plant. And I do want to point out now that I tend to interchange the terms marijuana and cannabis. I know there are some proponents of the medical use of marijuana or cannabis who really prefer that it be called cannabis. And so I'm not trying to make a political statement. I interchange the terms because in the medical literature, the terms are often interchanged. And when you're looking at legislation that allows us to use marijuana or cannabis in the US, it's usually referred to as marijuana. So I just wanted to make a note of that. But anyway, these phytocannabinoids are cannabinoids from plants. There's over 100 that have been identified in the cannabis plant, which, makes the pharmacology of marijuana or the cannabis pretty complex, and we'll talk more about that in a moment. The last term there is cannabis-derived pharmaceuticals. So these are prescription drugs that contain either phytocannabinoids from plants or synthetic cannabinoids made in the lab. And there are two that have been available in the US since the 1980s, dronabinol and nabilone. And these were both approved for the use of chemotherapy-induced nausea and vomiting and HIV-associated wasting. And they are synthetic versions of one particular cannabinoid. Currently in the US, there are two drugs undergoing phase 3 trials. These are drugs that are actually, they're manufactured in the United Kingdom, and they are made from a cannabis plant. So they actually contain phytocannabinoids, and we'll talk a little bit more about those later as well. But getting back to these phytocannabinoids found in the cannabis plant, as I said, over 100 have been identified. In addition to these phytocannabinoids, there's also other compounds in the cannabis plant, like terpenes, which are thought to have pharmacologic activity as well. But we know the most about two of the phytocannabinoids in particular, and you've probably heard of these. THC, or delta-9 tetrahydrocannabinol, is thought to be the primary psychoactive component of the cannabis plant. It's often used as a measure of potency or dose, and it is a partial cannabinoid receptor agonist. Cannabidiol, or CBD, is the major non-psychoactive component of the cannabis plant, and it's actually thought that it helps to decrease the psychotropic activity of THC. So in a way, it could act, maybe as a check and balance. And if you look at marijuana, the plant, up until the 1960s, for thousands of years, it stayed pretty much the same. And that meant that it had a roughly 1-to-1 THC to CBD ratio. In the 1960s, with the increase in recreational use, marijuana was bred to contain higher and higher concentrations of THC. So that ratio is skewed. And then who knows what happened to the, all the other phytocannabinoids that are in cannabis, with that change. Because, we tend to focus on these two, but then there's all those other phytocannabinoids as well. So here I've listed some of the pharmacologic actions of marijuana. This is from a report from the Canadian government for healthcare professionals in Canada. And this is a very detailed evidence, everything's cited, evidence-based report if you were looking to learn more. And I'm not going to read all of these to you, but I think one of the overall things to note right now is that when we're looking at the pharmacology and the therapeutic use and the adverse effects, we always have to consider that we may not know exactly which phytocannabinoid is causing which effect. And so when we get to the evidence, you'll see that a lot of times in studies, they just extract THC or CBD from the marijuana plant and put that into a capsule. And that means that it may not necessarily be the same as taking the whole plant or smoking the whole plant, right? Because you're missing out on all those other phytocannabinoids. And sometimes people call it the entourage effect of all the phytocannabinoids and, the other things like terpenes acting together to exert an effect on the body. So again, for instance, like the CBD or cannabidiol product that's available in certain states, I can't say for certain, which of these pharmacologic actions it may or may not have, being isolated on its own. So, but we do know kind of a lot about the CNS effects of marijuana because of its recreational use. So, recreational users seek to use it often to have a euphoria, but you can also see dysphoria and anxiety, a generalized CNS depression, tolerance, dependence. In the cardiovascular system, you can see tachycardia, supine hypertension, and postural hypotension. And then there's all these other potential effects. It may be antispasmodic, it may have anti-inflammatory effects, it may have neuroprotective effects, immunomodulatory effects. So it's pretty complex, and unfortunately we don't have a good and full understanding of it right now. And then this slide is just to illustrate further that complexity of pharmacology. So this is just looking at potential targets of action for one condition, epilepsy. So you can see that so far scientists have identified 5 different phytocannabinoids which may be, pharmacologically active to treat epilepsy. And you see THC listed there first, and CBD is next, second from the bottom. But then there's also these other phytocannabinoids. And then when you look at the potential targets, it becomes kind of mind-boggling because, for instance, by THC you see CB1 and CB2, and those are just cannabinoid receptors. But then look at all the other potential targets that THC can interact with. So again, this just illustrates the complexity of the pharmacology of the cannabis plant. All right, so now let's move on and talk about marijuana dosage forms. And before we get into that, I do want to define some terms that may be more pertinent to those patients who are using marijuana recreationally. But cannabis just refers to the flowering tops, leaves, and stalks of the mature female plant. And historically, the THC content of the cannabis plant was about 0.5 to 5%. But as I already mentioned, the cannabis plant has been bred to contain higher and higher concentrations of THC. And in Washington State, in our recreational marijuana, the average THC content is 16%. Hash refers to the dried resin from the marijuana plant. And if you look at the plant, there will be little tiny white beads, or kind of whitish pearly beads. And these are they're high in THC content. So when you isolate them and dry them, that makes hash, and that has an even higher THC content, 2 to 20% or higher. And then if you take that resin, dried resin, the hash, and make an oil-based extract of the hash, that's called hash oil, and that has a THC content of 15 to 50% or higher. Even I've seen reports of having a THC content of about 80%. And if you've heard of the term dabbing, and that probably applies more to recreational users, but we'll take a joint of cannabis and dab it in hash oil and then smoke it. And the point of that is to get just a real burst, or a really high dose of THC really quickly. Okay, so how is marijuana administered? There are 3 main administration routes: inhalation, oral ingestion, and transdermal. And inhalation by smoking is probably still the most common way that people use marijuana. Vaporizers have become increasingly popular. Theoretically, they would offer or they're touted as offering advantage over smoking, and theoretically it seems like that could be true because smoking burns the marijuana and the patient's breathing and all of that, versus vaporizers, which just heat the marijuana to a very high temperature and the patient breathes the vapors off of that. But I've not been able to find any evidence to support that vaporizers are actually safer, but theoretically that kind of makes sense. For oral ingestion, there are capsules and oils, tinctures that are used, but a very popular thing now is the edible forms of marijuana that entrepreneurs are developing, especially in light of recreational legislation passing. So it can be in things like butter and cooking oils, which can be used by the patient at home to bake or cook. It's in soda, coffee, wine, candies and mints, baked goods like cupcakes and Rice Krispie treats and cookies and brownies and crackers that look just like goldfish crackers and peanut butter crackers, and a lot of other forms like taco mix and ice cream, and so people have making these products have really been quite creative in putting them in a lot of different food forms. And then finally, the transdermal route has also become increasingly popular. There's ointments and sprays, suppository, there's even a patch. What's interesting is that some of the makers of these products advertise that, you know, it's just for localized effects and that it doesn't have systemic absorption. But then there are others that, you know, tout that their product is just a way to get, you know, marijuana systemically without having to smoke it or take it by oral ingestion. And so the bottom line is that without a pharmacokinetic study, you won't know whether or not, you know, there is a significant systemic absorption of these products. And that also, I want to point out that these products, so whether or not it's medical marijuana or recreational marijuana in states that have passed such legislation, what's available to patients, you know, is not necessarily just medical or just recreational. In Washington State, a patient will go to an outlet that's, you know, a marijuana store that's licensed by the state, and they just, all the products are available, and the patient can, you know, choose which one, you know, which one they want to use for either recreational use or medical use. Okay. Oh, I also did want to review, look a little bit about when the peak blood THC levels are reached for these different formulations. So taking marijuana by inhalation is certainly very reliable and rapid, with peak blood THC levels reached within 10 minutes after smoking or vaporizing. And in a savvy patient, that really allows them to be able to titrate the dose very, you know, well, so they, you know, avoid taking too much and maybe avoid side effects because they know just exactly how deeply to inhale to get the effect they want. With oral ingestion, it can take up to 4 hours depending on the formulation. And I think this is an important thing for healthcare professionals to understand and to be able to talk to patients about, because there have been cases where people have overdosed on oral forms because, you know, they take it and then nothing happens, you know, 30 minutes to an hour later. So then they take more and more. And, you know, by the time it's 4 hours, they've just ingested too much. And then finally, with transdermal formulations, unfortunately, I haven't been able to find any studies looking at or documenting, you know, how or if these formulations are absorbed. And, you know, quite frankly, it would really be dependent on the particular product, because not, you know, a patch is not going to be the same as ointment. And quite frankly, two people making, you know, marijuana ointments, you know, both of those could also have a different, you know, pharmacokinetic profile. So unfortunately, we're lacking on information regarding that right now. Okay, so then once you have this, the dosage form, and for both recreational or medical marijuana, it's generally required in states that have it that they have to label the THC and usually the CBD content as well. And so this was I mean, this wasn't a study per se, but there were some physicians who got together and tested some products. And this is specifically edible forms of marijuana in Los Angeles, San Francisco, and Seattle. And certainly it wasn't robust. You know, they only tested 75 products. But only 17% of the products were labeled accurately, 23% were underlabeled, and 60% were overlabeled. And then looking specifically at Seattle, where 23 products were tested, only one product was labeled accurately, 17% were underlabeled, and 78% were overlabeled. And that you can see that the actual THC range was less than 1 to 136. So, I mean, you know, essentially some of these products may not have contained any THC at all. So that's another thing. It's really buyer beware with these products because they're not regulated in the same way that, you know, as healthcare professionals we're used to with prescription products. Okay, so then next we're going to move into the therapeutic use of marijuana, or the potential therapeutic uses. But before we do, I did briefly want to review these cannabis-derived pharmaceuticals, because when we're looking at the literature about the use of cannabinoids,
be back online now.
Okay.
Yeah, if you want
All right, we're good to go. So, okay, so again, we're just going to briefly review these cannabis-derived pharmaceuticals. There are the two synthetic compounds which have been available in the U.S. since the 1980s, dronabinol and nabilone, which are synthetic versions either of THC or a compound very similar to THC. They're available in oral capsule form. Dronabinol is also available now as an oral solution. And again, the indications are for chemotherapy-induced nausea and vomiting and HIV-associated anorexia with weight loss. The two natural product-derived compounds that are undergoing phase 3 trials in the U.S. are nabiximols and cannabidiol. So nabiximols, and again, these products are manufactured in the U.K. Nabiximols is a cannabis-derived extract of THC and CBD. So the drug company grows cannabis plants and makes a pharmaceutical-grade product from them. And specifically, they make an oral mucosal spray with the dose being 2.7 milligrams of THC and 2.5 milligrams of CBD per spray. And if you remember what I call old-fashioned marijuana, pre-1960s, did contain a roughly 1-to-1 THC to CBD ratio. So this spray is kind of more closely mimicking that type of marijuana versus the types that are more readily available today that have a higher THC content. Nabiximols has been approved in 28 countries for the treatment of spasticity and multiple sclerosis. The cannabidiol is something that is made by the same drug company, but it hasn't been approved yet anywhere in the world. And it's a cannabis-derived Okay. All right. So first, let's look at why patients want to use medical marijuana. So this graph shows shows the reasons why patients in Colorado and Oregon used medical cannabis in the year 2016. And you can see by far the most common use is severe pain followed by spasticity or muscle spasms. And this is very consistent with other surveys and results. We see that the main reason why patients seek to use marijuana is for pain and spasticity. So then what does the evidence say? Well, the next 4 slides show a summary from the National Academy of Sciences report on cannabis. And this, they considered over 10,000 articles for their review. They got together experts across all areas of science, and they looked at 11 different aspects of cannabis. And one of those areas was the therapeutic use of cannabis or cannabinoids. And they divided the evidence as either being conclusive or substantive, moderate evidence, limited evidence, and then, insufficient or not enough evidence to support or refute use. And so for the conclusive or substantive evidence, they did see in 3 different conditions, treatment of chronic pain in adults, improving patient-reported MS spasticity symptoms, and the treatment of chemotherapy-induced nausea and vomiting. And then if we look at what were the agents or cannabinoids that they looked at, you can see that they were really all with cannabis-derived pharmaceuticals, with the exception of the use of inhaled cannabis for the treatment of chronic pain in adults. And there were, I think, at least 5 studies that were included that had patients who used inhaled cannabis for the treatment of chronic pain. Overall, they felt the results for pain, the results were just moderate or modest, and modest for patients who reported relief of spasticity symptoms in MS. And then, the treatment of chemotherapy-induced nausea and vomiting is with the products that are already FDA approved for that condition. So we would hope that this is the result they would see with that. Then if you're looking at what they found that there was moderate evidence to show that primarily nabiximols, so again, a cannabis-derived pharmaceutical, was helpful for improving short-term sleep outcomes in patients with sleep disturbance associated with obstructive sleep apnea, fibromyalgia, chronic pain, and MS. They felt there was limited evidence to support the use of cannabis or cannabinoids for all of these different conditions. Clinician measured MS spasticity, Tourette syndrome. And then I will point out, like, for instance, the study looking at improving anxiety symptoms and social anxiety disorder, that was just a single study, and it was giving cannabidiol before public speaking, so a very limited kind of look at the use of cannabidiol, and that's for anxiety because it was very specific to just public speaking one time. And then improving the symptoms of PTSD, that was with nabilone. That was also a single study, and it only involved 10 patients. So this evidence really is quite limited. There was, they found that there was limited evidence that actually showed that cannabis or cannabinoids may be ineffective to improve symptoms associated with dementia, to improve intraocular pressure in glaucoma, and to reduce depressive symptoms in patients with MS. And again, you see the use of these cannabinoids and not medical marijuana or the cannabis plant itself. And then finally, they said there was no or insufficient evidence to support or refute the use of cannabis or cannabinoids for all these conditions, including epilepsy and Parkinson's disease. But then, specifically, let's look at the therapeutic use of medical marijuana in older adults. And, first of all, do older adults use medical marijuana? They do. The prevalence is really unknown. There was a survey that was done a few years ago, or, I guess probably over 4 years ago now, a survey in 31 countries that included close to 1,000 people, and about 40% of those were from the US. And in that study, they found that 6.5% of medical marijuana users were aged 61 to 76. So then the next question is there evidence to support the use of medical marijuana in older adults? And before we get into some of the studies, I did just want to summarize what, for some conditions which we see more commonly in older adults, glaucoma, Parkinson's disease, and Alzheimer's, kind of what the medical groups are saying regarding these conditions. So with glaucoma, the American Academy of Ophthalmology and the American Glaucoma Society do not recommend the use of marijuana for glaucoma. You can see with the National Academy of Sciences report, there was actually evidence, or limited evidence, that cannabis or cannabinoids were actually ineffective to treat glaucoma. But then it's, this just brings it into the real world. In Washington State, glaucoma is an indication for which patients can get a medical marijuana authorization in this state. I think, as part of the recommendations of these societies, some of the things they talked about were, for instance, with inhaled marijuana, you would have to take it every 3 hours in order to decrease intraocular pressure over a 24-hour period. So that seems unlikely. And then also kind of commenting on that we have other treatments for glaucoma that we know are effective and don't require multiple dosing every 3 hours. With Parkinson's disease, the American Academy of Neurology review in 2014 reported that an oral cannabis extract was probably ineffective for levodopa-induced dyskinesias. And then for Alzheimer's disease, no group has made kind of an opinion on this, but I think further research is needed. And we're going to look in particular at some of the studies surrounding this because I think it is of interest to people working in geriatrics. So this first slide here is just a summary of a systematic review that looked at specifically the efficacy and safety of medical cannabinoids in older subjects. And the first trial was from the 80s. It was looking at THC compared to prochlorperazine for chemotherapy-induced nausea and vomiting. And this is really not even clinically significant because we don't, the regimens for chemotherapy are much different than they were in the 80s, they are today. And, the regimens to treat nausea and vomiting are also much more different and complex, than just using prochlorperazine. But then if you look at the more recent studies, so the second one there listed was in 2004, a randomized placebo-controlled crossover trial that looked at oral THC CBD preparation for levodopa-induced dyskinesias, and they found no improvement. And then the last study, which only included 5 patients, looked at the use of sublingual THC CBD compound for carbon dioxide-induced breathlessness, and they found no improvement. But this is a review of looking at the use of cannabinoids in late-onset Alzheimer's disease. So there were 4 studies that they included. And you'll note that, most of these studies are quite small. The study that contained the most patients, they didn't actually give the age of the patients, though it is late-onset Alzheimer's disease, so we would think that these are older patients. And you'll also note that dronabinol was used in all of these. So it was using a very specific product. It wasn't using, medical cannabis or, marijuana, the plant. And they found they looked at different outcomes or indications. So, the first study found that there was a decreased severity of disturbed behavior. The second study found that there was reduced nocturnal motor activity and agitation. The third study, showed there was reduced nighttime activity and strengthened circadian rhythms. And then the last, which was a retrospective chart review, did see a decrease in all domains of the Pittsburgh Agitation Scale and an improvement in sleep duration. And then this slide summarizes 3 individual studies that are the most recently published. And here we kind of get mixed results. So the first 2 are from the same group of investigators in Europe, and they're looking specifically at oral THC. And again, not a huge number of patients. And they both looked at change in NPI score. The first study showed that THC did not reduce the NPI compared to placebo, and then there was no difference in treatment groups in the second study. And then the most recently published study was by Shelliff et al. In 2016, an open-label 4-week study of 10 patients using they had compounded a medical cannabis oil, and they did find that there was a decrease in the CGI and NPI scores. So overall, not a lot of robust evidence, and it's kind of conflicting. And so I think, before really recommending the use of marijuana, in this for this indication, we would need further research. And also, if you really are looking at the evidence, they're not using marijuana, the plant. They're using very specific compounds, either dronabinol or compounded THC or a THC CBD preparation. All right, so then moving on to the adverse effects of marijuana, and I've divided them into acute, toxic, acute, and then chronic. So kind of 3 categories. And we'll start with the acute toxic effects of marijuana, and these are as seen in overdose and accidental ingestion by children. And that, unfortunately, is a problem that is increasing in the US. So the reaction you can see in the CNS, you can see anxiety, hallucinations, panic, drowsiness, lethargy, ataxia, confusion, and in the worst case, seizures and coma. In the cardiovascular system, you can see tachycardia and chest pain. And then this respiratory depression is kind of unusual because we don't normally think of marijuana or cannabis as causing respiratory depression. And I don't think that it's ever been reported in adults, but in children in particular, in some of these cases of accidental ingestion, it has been, noted during admission that the patient had respiratory depression. And in the GI system, you can see nausea and vomiting and abdominal pain. So let's look a little bit more about this accidental ingestion by children, because when you look at the data or some of the studies surrounding this, most of the kids are getting into edible marijuana products. So it's by this oral ingestion of these marijuana-infused foods. And most of it's not occurring at their home. It's occurring at their grandparents' home or a caregiver. So this is why it's important for our older adults to know in case they're grandparents and watching their grandchildren. So you can see here on the left, this is an edible marijuana product. It's marijuana gummy bears. Each gummy bear contains 10 milligrams of THC, which is often thought to be a dose of both medical and recreational marijuana. It depends on where you live. For instance, in Oregon, they only allow 5 milligrams of THC per dose. But so in this bag, there's 10 gummy bears, which represents 100 milligrams of THC. So if somebody ate the whole bag, that would be an overdose, and particularly, obviously, for a child, where the dose, the dose would have more of an effect. And then on the right, you see the non-edible gummy bears, and these aren't even candy. So these are just there. It's a dietary supplement. It's gummy vites for children. Neither one of these products are monitored by the FDA, but you'll notice that they do put a child safety cap on the vitamins, even though they're probably not, or they're not as toxic. And I do want to say that though, this picture is a little old. So now states are trying to institute child-proof packaging, but if you have ice cream or a cupcake, it'll be interesting to see how they're really going to child-proof that, because I think that's challenging. And then looking at the annual rate of marijuana exposure among children younger than 6 years of age. So this is looking at National Poison Data System information from 2000 to 2013. The bottom dashed line shows states where marijuana is not legal. And you can see that it stayed pretty steady, maybe increased slightly. And then the top solid line shows where states where marijuana was legalized prior to 2000. And you can see a very significant increase, and this is statistically significant increase in the rate of children who have been exposed to marijuana. And thankfully, while the overall rate, the actual number of children is relatively still small, because this is, the rate per million children, this increase is concerning. And when you look at these kids, the mean age is a little less than 2, and this is consistent with other reports. 75% were exposed through oral ingestion, and then about almost 20% required admission after exposure. All right, so then looking at the acute adverse effects of marijuana, so not as seen in overdose. In the CN, these are often just the same types of symptoms, but not as severe. So there you can see anxiety and panic, and that's often not something that people associate with using marijuana, particularly naive users. And those are the users, naive users, who are most likely to have anxiety and panic, about 30% of them. And in the worst case, they could have psychotic symptoms. Sedation, dizziness, and confusion can also be seen, and this is obviously very concerning in the older adults we take care of, just because we're already concerned about medicines that can cause these effects due to risk of falls and fractures. In the cardiovascular system, you can see tachycardia and orthostatic hypotension. We know from data looking at recreational young users that they can usually tolerate these excursions in the cardiovascular system, but what we don't know but are potentially concerned about is how an older adult with an underlying cardiovascular disease or problems, how they would be able to tolerate such excursions. And then there is dose-related impairment of reaction time, information processing, coordination, motor performance, et cetera, and that all does lead to an impaired ability to drive and an increased risk of crashes. And the National Academy of Sciences report also looked at this specifically, and they the best evidence they say also is that using marijuana impairs driving and increases risk of crashes. Okay, so then looking at the chronic adverse effects, because if patients are using marijuana as medicine, they may be taking it chronically. And for sure there is a risk of dependence. I do have to say it is less than other substances like alcohol and heroin and tobacco, but there is a risk nonetheless. And so it is 1 in 10 of longtime users are at risk of dependence, 1 in 6 of adolescent users, and then 1 in 2 to 3 of daily users. If it's smoked in the respiratory system, you can see chronic bronchitis and decreased pulmonary function, pulmonary infections, which could all be concerning, especially if we have older adults with, COPD. Precancerous lesions have been seen, but there isn't really an association now between smoking marijuana and lung cancer. And then in the CNS, you can see memory and cognitive impairment, psychotic symptoms and disorders. Those definitely would be worse, or you're more likely to have those kind of symptoms if you have an underlying condition that predisposes you, such as schizophrenia. And then finally, there is this kind of oddball thing that they've been seeing in chronic kind of higher dose users of this cannabinoid hyperemesis syndrome, where people will, often present to the ER, to their primary care doctor with this, and, they can't stop vomiting. And it's relieved by taking hot showers, which is one thing that kind of differentiates it, or, it could be advice that you give to the patient if they present with this, because that, for some reason, seems to relieve it. And then we also kind of have to worry about potential contaminants in cannabis, because different states, again, all have different rules regarding either medical marijuana or recreational marijuana, if they have passed those laws about what contaminants or will even look for contaminants in cannabis. And cannabis can be contaminated with aspergillus and bacteria. I've heard of cases where a transplant patient developed aspergillus because the marijuana was great. She was smoking it for her pain, and it was really helping, but then she got aspergillus. And that took a couple of years to resolve. There could be heavy metals, aluminum and cadmium, pesticides, glass beads and sand. That might be cut into marijuana to make it look like it has a higher THC content, like it has more of that resin that's found on the leaves. And then sometimes they could actually cut other psychotropic substances into it, which could have their own effects. And then finally, I'll look at the potential drug-drug interactions. I am a pharmacist, so I am interested, I have a particular interest in drug-drug interactions. And I think, again, the kind of caveat hanging over all of this is that we don't know when a patient is using a marijuana product what phytocannabinoids it contains. And even if they're buying the same product over time, it could even differ in its cannabinoid profile. But what we do know is that it seems like THC is metabolized by the cytochrome P450 enzymes 3A4 and 2C9, and that CBD, or cannabidiol, is metabolized by 3A4 and 2C19. It also seems like cannabidiol, or CBD, may be an inhibitor of some enzymes as well. But with that information, we can try to make some educated guesses about potential drug interactions. And then the rest of these, I think kind of the biggest one we could probably, take away and easy to remember is just the risk of increased CNS depression when using with any other drug that can cause CNS depression. And we already know this, regarding other drugs. But if marijuana is combined with alcohol, phenytoin, opioids, benzodiazepines, anticholinergics, muscle relaxants, there's just going to be an even heightened risk of CNS depression, which can be concerning in older adults. And then looking at some of the rest of these, I guess probably the most clinically significant one would be warfarin. And that is one that, when I've worked in an anticoagulation clinic, that I've had to deal with. So basically, if somebody's kind of stable on warfarin and then they smoke or use marijuana, they can see an increase in the INR. And if they're sporadically using marijuana, then that obviously makes the interaction harder to deal with. Okay. So as we're wrapping up, I just wanted to summarize some general challenges. So first, the pharmacology of cannabis is very complex, and we don't fully understand it. We know that it has over 100 potentially active ingredients, which can vary in concentration from plant to plant. And then I didn't even mention it, but within a given plant, that cannabinoid profile can change based on growing conditions, you know, the soil, the temperature, the sunlight. And all of these potential active ingredients are interacting with many receptors in the bodies in ways that we just don't really understand very well right now. The production and manufacturing of marijuana products is not well regulated. And I can't remember if I mentioned, but I do tend to lump them together with herbal products and dietary supplements, because all three of those things are not monitored by the FDA for efficacy, safety, or good manufacturing processes or practices. And then finally, doses of cannabinoids in marijuana products vary widely and may not be consistent. And then we know they also may be inaccurately labeled. Some challenges specifically for medical use. You know, we're lacking a lot of evidence because marijuana use is still deemed illegal by the federal government. Most marijuana research that we have has been in people who smoke for recreational use. So when we're really looking at a lot of these adverse effects and things like that, it may be, you know, not necessarily about a particular, you know, THC, CBD compound, but it, you know, it's more about just smoking marijuana, the whole plant. Most rigorous research regarding medical use of cannabinoids has been with cannabis-derived pharmaceuticals. And then finally, the scientific evidence to support the use of edible and topical forms of medical marijuana, which have really gained popularity, is lacking. So what can we do with all this information? I think regardless of our profession or, you know, where we practice, you know, whether there are marijuana access laws or not, I mean, people are probably using marijuana everywhere because they can somehow get access to it if they really want it. And so I think there's just some harm reduction topics that we can discuss with patients as it comes up. And I think it's very important because there is a lot of misinformation about marijuana available to patients on the internet and word of mouth. And so I think it's important for us to be able to maybe counterbalance and definitely correct misinformation, because I've had patients ask me some things about marijuana that were definitely misinformation. So the first step is obviously to find out if patients you're working with are using marijuana, and that is, you know, you need to ask about its use. We can counsel on the variability and quality and concentration of the marijuana products, counsel patients on the delayed time to effect after ingestion or oral ingestion of marijuana, counsel on patients on potential adverse effects, and in elderly, we might want to be especially cautious if they're having drowsiness, confusion, dizziness that could lead to falls and fractures. We can counsel on potential drug interactions, particularly interactions with any other CNS depressants, advise patients not to drive after using marijuana, and finally to warn of the risk of accidental ingestion of children and also pets. We didn't talk about pets, but there have been an increase in reports of pets who have unwittingly ingested marijuana products. And then finally, getting down to this, authorizing the use of medical marijuana. And it's obviously going to depend where you live, if it's even possible that you can provide an authorization, and also on your profession, if you're a provider who is authorized in the state where you live to provide such an authorization. And, you know, obviously it's highly individualized based on the patient, the provider, and the potential indication for which the patient is seeking to use marijuana. And if you are allowed to do it, you know, and as a provider in that state, you need to follow all the rules and regulations. I think it's a good idea to counsel on alternative treatments and comparative efficacy, with the point being that we're really lacking information about comparative efficacy, you know, compared to the, you know, the standard treatments that we use, you know, for pain, seizures, glaucoma, et cetera. And then finally, the provider can counsel on all harm reduction topics. But I think getting back to this issue of it being highly individualized, I think sometimes I get flack for not being more forceful about what my opinion is. But I mean, I truly believe it is highly individualized. Because as a provider, I mean, just looking at it from a provider's standpoint, you know, a provider may just be an evidence-based purist, and when looking at older adults, just say there's just not enough evidence to support the use of marijuana as a medicine in older adults, just because we don't have the studies. Or the provider could just feel uncomfortable authorizing marijuana because it is a Schedule I substance, or the provider could work for the VA system where they're not even allowed to provide those authorizations, even if they live in states that allow medical marijuana. And then a provider just may feel uncomfortable. Maybe they don't have a problem with the patient trying marijuana, but they just realize that the products that we have available, are not well regulated, may not be labeled properly, and things like that. But I do want to, and I respect those viewpoints. But I wanted to just do a little exercise here where we're all going to pretend we're PCPs. And we're practicing in Washington State. And the patient comes in, a 72-year-old man, just for an office visit, and he is requesting a medical marijuana authorization. And he's smoked marijuana in the past for recreational use, in his late teens, early 20s, but he hasn't used it since then. And let's consider 3 scenarios. So in the first scenario, he's terminally ill with cancer, and he's requesting the authorization because he's having really, intractable pain that's not well relieved by, opiates and other medicines. In the second scenario, he is requesting the authorization for chronic back pain, and he has a pain contract with you where he gets 20 oxycodone 5 milligram tablets every month, and he's saying, gosh, if I could get this authorization, maybe I can decrease the use of my oxycodone. And then in the last scenario, he comes in and he's like, oh, I think I want to try using medical marijuana for my glaucoma. And, he's been treated by an ophthalmologist. His regimen for glaucoma has been working really well, but he's decided he wants to take a natural approach, and he's already talked to his ophthalmologist, and the ophthalmologist has declined to provide the authorization. Okay, so these are 3 very different scenarios. And I think in the first scenario, we all might be a little more inclined to be okay with using medical marijuana. In fact, there was a survey in JAMA where they had a similar case, but it was a female who had metastatic breast cancer. And the majority of providers who responded, would support the use of medical marijuana in that patient. It's terminally ill, it's a very limited use. And in the last scenario, it might be, easier, especially as a primary care provider, if the specialist has already recommended against it or doesn't feel comfortable doing it, and then, what if we really are lacking data, and we can kind of show him that and, say, wow, if you smoke it, for instance, you're going to have to smoke every 3 hours in order to get relief. That might be a little bit easier to say no for some of us. But I think the middle case, the middle scenario, just leaves a lot of questions. And we probably would need to have more information, right? We would need to know the patient's other conditions, the other medications they've tried, the other non-pharmacologic therapies they've used, PT and exercise, and that kind of thing. And so I think, this is why it's highly individualized. And yeah, so I think, there was one other thing that I forgot to mention, but to put into context about marijuana use. And that's when they did a survey, just not of older adults, but just the general population, 10% use for medical use, 36% use for medical and recreational use, and the rest used for recreational use. So we do have kind of a big percentage of the population who is looking to use marijuana both as a medicine and as a recreational agent. So that's also just something to consider. So with that, that's all I have to present, and so now I'll open it up to questions.
Okay. So I have some questions already coming by.
Okay. Or she has one too, I don't know.
I have it on. So the first one is asking, on slide 34 you had, and I think the NPI, I think is the neuropsychiatric inventory,
yes,
but they're wondering what CGI is?
Okay, yeah, and let me, and do I need to repeat the question? Or
No, not when I'm
okay. Okay, that's the clinical global impression, which is another measure to look at symptoms and treatment response in different mental disorders.
Okay.
And yeah, I'm sorry, I'm not too familiar with it, but yeah, it's just another way to kind of.
And then someone asked an interesting question from Sika. How about any insurance coverage for any of this?
Oh yeah, so as far as I know, there is not insurance coverage because this is, these are not, just like insurance doesn't often cover a lot of herbal or even over-the-counter products, which are regulated by the FDA. Now, if you're looking at the cannabis-derived pharmaceuticals, like dronabinol and nabilone may be covered, depending on your insurance plan, but that's not really medical marijuana or medical
Wonder
cannabis.
if they could claim it on their income taxes as a medical expense.
Oh.
If they had the copy of the authorization.
Yeah, I don't know. And that would probably really differ state to state.
Yeah, that's true. Maybe you wouldn't want to let IRS know.
That's true.
It's a federal issue.
That's true.
Okay, so any updates on evidence of the effects in pregnancy, breastfed mothers, or teens, moving, I guess, away from older adults?
Wait, so the question was any...
Updates.
Oh, updates. I think it's kind of the National Academy of Sciences report was basically don't. They're recommending against the use in pregnant women and breastfeeding mothers.
Okay.
And then, can I take the question that's in the room? Okay, yeah.
I was wondering what your sense of, what I've seen in the hospital is when people come in, and I work in the burn unit at Harborview.
Oh, okay.
And if they are chronic marijuana users, and then they have a potential injury where they have increased pain, and we have to try to treat their pain, can you speak to that? If there's any tricks to that, or is you've seen it and it's read about it, or?
Okay, so your question is, just to summarize for everybody who's listening, so when you worked on the burn unit and you would have people come in who had chronic marijuana users, what are some tricks or tips?
It appeared in my very small sample size that their pain would be untreated by just opioids.
Oh, okay.
Or Tylenol and the sort of agents that we try.
Right. So the pain in these burn patients who were chronic marijuana users before was unrelieved by the therapies used in the hospital, like opioids and Tylenol and SEDS. Unfortunately, I don't have any experience or really an understanding, or I guess I can't really answer your question.
Yeah. I think it may become an issue as the usage increases, and we're having more potent edibles and things that people are going to be chronic users, and then I guess the question is, when they're in the hospital, how is that?
Right. Yeah, and in the hospital you have the issue of access because hospitals don't allow patients to use their, even if they have medical marijuana authorization, they're not allowed to use it on the hospital premises. So yeah, I guess it's an issue. We'll have to, kind of see how it unfolds. But.
So a question from Laramie, Wyoming which is also interesting, what is the price comparison of cannabis-derived pharmaceutical versus recreational use marijuana for treating chemo-induced nausea and vomiting?
Oh, okay, that's a great question, and I don't know if I have a good answer to that. Dronabinol and nabilone, they're older agents now, so I don't think that they're exorbitantly expensive. Yeah, and I think it just depends on where you live, and if you're buying medical marijuana, or you're buying recreational marijuana, or you're buying, marijuana kind of under the under the radar. It really probably depends on the price. So I know that both medical and recreational marijuana will cost more than kind of what we call black market marijuana. And then also, I guess, in case people are wondering, and especially in Washington, I get the question, well, we have recreational marijuana, why do people even use medical marijuana? And it's because if you have a medical marijuana authorization in Washington state, you're allowed to, purchase more marijuana at a time, and you also don't have to pay the use and sales tax. So it makes it a little bit more affordable, but it's still more expensive than buying it kind of under the table, so to speak.
Are you seeing any issues with the new anticoagulants and marijuana users?
Okay. That's a great question. I mean, I haven't seen it reported in the literature. I don't currently work in an anticoagulation clinic, but that would be, I should ask my, my colleagues who do, because I'm not aware if there's any interactions.
And any thoughts how this might affect someone with hepatitis C?
The use of medical marijuana?
I guess.
Or, okay, I'm just going to go back here. Sorry. I'm just looking back at our, because I think that using for, sorry. So I know, like so here in Washington State, you can see that hepatitis C with debilitating nausea and intractable pain is an indication. So I'm just wondering if the question is regarding use for that particular condition, or if there's contraindications. I think, if you're looking at, I mean, the best, if there is a specific study looking at the use of hepatitis C, I haven't evaluated it, but when we're looking at, the best review of evidence we have so far is this National Academy of Sciences report, and it wasn't specifically teased out there. But that doesn't mean there couldn't be a study looking at it, but, it's probably not really robust if it didn't make it into that review.
And someone asks, can one get a DUI for use of medical marijuana, I'm assuming?
Yeah.
Okay. And are pot shops versus homegrown any different when it comes to safety?
Okay, that's a good question. I think, you have to remember that any of the growers, and the pot shops have to get the marijuana from somewhere, so they are getting it from some grower. And I think you have to remember that it's just, unfortunately, really buyer beware. I think probably, I remember there was a story in the Seattle Times, probably now over 5 years ago, about a father who grew, for his child who had intractable epilepsy, he grew the marijuana himself. He made it into, he compounded it himself, and then he sent it to a lab to be tested for potency so he would know exactly how much to give his daughter. So if you want to really know, I guess you kind of have to do it all yourself, because, when you're relying on someone else, there could, you don't know. I think, and that's the real frustration with medical marijuana, I think, especially as a pharmacist, is because, right, we don't always do evidence-based strictly, and, sometimes we try things for people, right? But it's really hard to even get to that step when we don't know if the products are safe and what they contain and that kind of thing.
So Brent is clarifying the question about hepatitis C, and he says, hepatitis C with chronic pain and essentially living in a bathroom.
Oh, okay. So, I think there's a thing where we may not have evidence, but, there probably are anecdotal reports, because I think for, like in Washington State, a lot of some of these conditions I know for sure got on the list because specific patients were advocating for their inclusion. So, it may be that it's, I don't know if we don't have evidence to say specifically for hepatitis C, but anecdotally, patients may report that it's helpful.
That makes sense. And then someone was asking, I'm going to try and answer it, and then you tell me if I'm right. Is the patient who's under doctor's authorization for medical marijuana, when they get a driver's license, is this waived? And I would say probably not. I don't think the drivers, in other words, the issue of potentially getting a DUI or something.
Oh, okay.
I would say chances are the driver's license folks don't want to get into that area.
Yeah, and I'm a little cautious about answering questions like this, because somebody from the Department of Health specifically told me I shouldn't practice law. So I am a little nervous.
Well, then I will.
Because I asked another question. She's like, that seems like you're practicing law. I said, I'm just trying to qualify.
I can't imagine there being
really, I don't. That seems, you don't get a free pass.
Just think of some of these other influences of narcotics and
Right.
You might want to repeat that.
Oh, okay. So somebody just mentioned the case of people being unfit to drive because of their under the influence of opiates or narcotics. Yeah, and they could have a paying contract with their provider, but that doesn't mean that they can't. Yeah, they're safe to drive.
Yeah, that's a good question. Any other questions in the room here? So I think, well, there's one. Oh, it's just a thank you.
Oh, okay.
So thank you very much.
Yeah, well, thank you for your time and attention.